Hello, and a very good evening to all our viewers. Welcome to Clin Shots, your clinical dose of short and focused discussions. Clin Shots, comprising of niche clinical discussions every month, is our special offering for you, our healthcare practitioners who seldom have any extra minutes to spare. This series will comprise of 4 to 5 episodes catering to specific health domains for a month and has been developed by careful scientific deliberation and inputs from experts from the healthcare industry and after conducting interesting surveys from our audience. One can also register in advance for all the sessions completely free of cost. And you can also watch us live every Tuesday, 6 p.m. exclusively on Doc Plexus. Last month of August, we held discussions around the treatment and management of adamant asthma. This month, we will be focusing on the vast specialty of pediatrics, bringing to you some very interesting clinical topics from the subspecialties of general pediatrics, neonatology, pediatric hematology, and pediatric emergency medicine by our expert speakers. Today, to begin this month's pediatric special, we have with us Dr. Ankit Yadavendra, who will be talking on the approach towards managing rickets. Dr. Ankit Yadavendra has completed his MBBS from Dr. Vaishampayan Memorial Government College, Solapur, Maharashtra, with excellent academic record. He has also completed his MD in pediatrics from the prestigious Bombay Hospital Institute of Medical Sciences in Mumbai. He has worked as a pediatric resident at Lokmanya Tilak Municipal General Hospital, Sion, and as registrar at the Manohar Vaman Desai Municipal Hospital in Mumbai. He has published 45 notes to PG, book for PG aspirants, Solved Papers Pediatrics for PG students, which was also the bestseller rank one on Amazon in pediatrics book category, and Solved Papers OBGY Neonatology questions. He has a medical education channel on YouTube and also leads many MCQ discussion groups on social media. So without further ado, let's begin the first session of Clin Shots, Approach to Rickets. Welcome, Dr. Ankit. You may please begin your presentation.
Hello, everyone. I am Dr. Ankit Yadavendra. I am a pediatrician and I practice in Malad, West Mumbai. I thank Doc Plexus for giving me an opportunity to present this topic. So my today's topic is approach to rickets. So this is a very common topic nowadays we see in our daily practice. So basically, what is rickets? So if we talk about the definition, in rickets, there is deficient mineralization at the growth plate in the bones, whereas osteomalacia refers to impaired mineralization of the bone matrix. So usually rickets is something which occurs in children, whereas in adults, osteomalacia occurs. Now, what are the clinical features? So we'll quickly move on to the clinical features and management because our topic is approach to rickets. So clinical features include failure to thrive, listlessness, weakness of the proximal muscles, delayed closure of the fontanelles. And then you can see parietal and frontal bossing. This is also known as caput quadratum. Also, we see craniotapes, which is soft skull bones. This we can examine by palpating the skull. Enlargement of the costochondral junction along the anterolateral aspects of the chest, which is a rachitic rosary. So here you can see in the left image, you can see the costochondral junction, which is easily seen. And same thing you can see in the X-ray also. Now, how to distinguish between rosary due to scurvy and rosary due to rickets? So in rachitic rosary, it is not the costochondral junction are not so sharp, whereas in scurvy they are sharp on palpation. Then comes Harrison sulcus. Harrison sulcus, it is a groove at the lower margin of the thorax, and it is mainly caused by the pull of the diaphragm, which attaches to the lower lips. So because we see that there is weakness of the cartilages, weakness of the bones. These symptoms and signs are seen. Sternum may be pulled into a pigeon breast deformity. This is also known as pectus carinatum. Widening of the wrists and ankles. This can be easily examined by palpating the wrists. Double malleoli or the Marfan sign. Pot belly and visceraptosis. We can see bowing of the distal radius and ulna, which is known as coxa vara. We can also see lateral bowing of the femur and tibia, which may be genu valgum or genu varum, and kyphoscoliosis, lordosis. At the time of weight bearing, mainly when the children start crawling, we can see the symptoms and we can see bowing. So most commonly lower limbs are involved. Then there can be fractures, delayed dentition or caries, craniosynostosis, respiratory infections, and atelectasis. Hypocalcemic symptoms may be there due to tetany, scissors, stridor, or laryngospasms. So these are the clinical features. So when we come across a growing child, usually in the preschool period, we can examine every child and we should be able to rule out whether the child is having rickets or no. Now, radiographic evaluation. Suppose we have come through a child who is having clinical features of rickets. Now, how to evaluate? So, radiographic evaluation for less than 3 years of age, we have to do the anteroposterior view of knee, and for more than 3 years of age, we have to do anteroposterior view of the wrist. Then, widening of the epiphyseal plates can be seen. Loss of zone of provisional calcification at the epiphyseal or metaphyseal junction. Then we will see cupping, splaying, formation of cortical spurs and stippling. Appearance of the epiphyseal bone centers is delayed or they may be small. Now, what do you mean by fraying? So, fraying is indistinct margins of the metaphysis. Splaying is widening of the metaphyseal ends, and cupping is concavity of the metaphysis. So here you can see this X-ray. In this X-ray, you can see there is cupping, fraying, splaying. Also, you can see that there is less calcification in the bones. Also the epiphyseal centers appear small. Now, diaphysis is osteopenic and cortex becomes thin. Here you can see in the previous X-ray, the cortex is so thin. Similarly, trabecular pattern is reduced and it becomes coarse. Deformities of the shafts of the long bones are present. Looser zone are seen. Looser zones, what are they? They are 2 to 5 millimeter wide radiolucent areas with sclerotic borders, and they are usually bilateral and symmetric, and they are perpendicular to the cortical margins of the bones. So you can see these are the looser zones. So common sites for looser zones or pseudo fractures include femoral neck, medial part of the femoral shaft, just below lesser trochanter on pubic and ischial rami. They may also be seen in ulna, scapula, clavicle, rib, and metatarsal bones. Pseudo fractures are also seen as hot spots on bone scans. Now, what are the laboratory investigations? So, we see a child coming to OPD, 2 years old child, with mother complaining of uh, poor growth and weak bones, and there may be history of repeated fractures. There may be history of malnutrition. So, how will we evaluate? First, we did X-ray. On X-ray, we found the signs of the rickets. Now, laboratory investigations. So, we will do alkaline phosphatase. Alkaline phosphatase, it is an excellent marker of disease activity. So, if levels are more than 1500 units per liter, then it means disease is active at present. Serum calcium is low, less than 8.8 milligram per deciliter. Serum phosphorus is low, less than 3.7. Serum vitamin D, 25D, is low, and insufficient is less than 20, and deficient is less than 12. Serum parathyroid hormone levels are elevated. Urinary calcium and phosphate are increased. So we see that vitamin D basically acts to increase calcium in the body. So what it does, it prevents calcium excretion from urine, also from the intestine. It also prevents phosphate excretion from the urine and from the intestine, and it causes them to go into the bones. So from kidney and from intestine, it will go into the blood and then it will go into the bones. Okay. Now, how will we manage rickets? So saw the child, we have diagnosed that it is rickets. How will we manage? Most of the time, we see in our OPD that we give vitamin D. We may give sachets or we may give capsules. But how will we manage? So we have to give cholecalciferol, which is we have to give 1,000 units per day in preterms, 2,000 units per day in infants, and 3,000 international units per day in children more than 1 year of age for a minimum of 12 weeks, or we can give 60,000 international units fortnightly, that is every 14 days, for a total of 5 doses. So basically, previous guidelines were different. Previously, we used to say that we have to give 50,000 units every week for total of 6 weeks. And then now the guidelines have changed. They are now 60,000 international units every 2 weeks for 5 doses. And then when we give this treatment after the fifth dose is completed, we have to see whether there is any improvement in biochemical and radiological parameters. Also, when we are giving vitamin D, we have to see whether calcium supplements are given or no. So for preterms, we have to give 200 mg per kg per day of preterms calcium. For infants and children more than 1 year of age, we have to give 500 mg per day of oral calcium. Now, cholecalciferol for prevention, usually we see and we give also to preterms and infants. So for prevention, we have to give 400 units per day in preterms and also in infants. And if child is more than 1 year of age, we have to give 600 international units per day. So previous guidelines said that in preterms we can give up to 800 units, but now it is recommended to give only 400 units. Along with that, we have to give oral calcium in preterms 200 mg per kg per day. For infants, 250 to 500 mg per day. And for children more than 1 year of age, we have to give 500 mg per day. This is to prevent calcium deficiency. And calcium carbonate is preferred because it has 40% elemental calcium. And it is preferred over calcium citrate and calcium gluconate as it is easily absorbed and it should be given with food. Also, we should take care that it is not given with iron because sometimes what happens is that we prescribe hematinics also and calcium also. And if both of them are taken together, then absorption is poor. So it is important to ensure that children receive adequate dietary calcium and phosphorus. And this dietary intake is usually provided by milk, formula, and other dairy products. Now, suppose child is having tetany or laryngospasms or seizures, which is suspected or diagnosed that it is due to uh, vitamin D deficiency. In such cases, we have to give 2 ml per kg of 10% calcium gluconate, which is administered IV slowly under cardiac monitoring because calcium may cause bradycardia. So it causes heart blocks. So it may lead to arrhythmias. So we have to do it under cardiac monitoring. Initially, we will give IV calcium boluses, and then every 6 hours we have to give for 2 to 3 days until ionic calcium normalizes. So we have to understand that calcium in blood is in protein bound form and also in ionic form. Protein bound calcium has not much in does not play much role, So ionic calcium is the one which is very important. Thereafter, oral calcium supplementation can be given at 40 to 80 mg per kg per day. So this is for the management of tetany or laryngospasm or seizures. Now for pregnant and lactating women also, we should give 600 international units per day of cholecalciferol and 1200 mg per day of calcium. In cases, suppose there is vitamin D dependent rickets type 1 or hypophosphatemic rickets, or a child has been operated for some thyroid surgery and his parathyroid glands are also not there, so he's having hypoparathyroidism, or there is a child with chronic renal disease or chronic liver disease. In such cases, we cannot give cholecalciferol. We will have to give calcitriol. So calcitriol, it is the activated form, 125 cholecalciferol, and this we have to give 0.01 to 0.1 microgram per kg per day in 2 divided doses orally. For vitamin D dependent rickets type 2, calcitriol may be required in higher doses, 50 to 60 microgram per day. So you can see when there is vitamin D dependent rickets type 2, then the receptors are almost resistant to vitamin D. So we have to give very high doses of calcitriol. Now this is the flow chart of how to approach renal rickets, resistant rickets. So if we have diagnosed a child, we saw the signs of rickets, we gave treatment vitamin D. Now, after giving 5 doses of 60,000 international units of vitamin D, we will re-examine the child. We will repeat the X-ray and also we will see the blood parameters. So if we see that X-ray is improving, healing, parameters are better, it means it is nutritional rickets. And in such cases, we have to just complete the treatment and then stop. Suppose there is no improvement, there is no healing in the rickets. So it means it is renal rickets or resistant rickets. So in that case, we have to do serum creatinine. If serum creatinine is high, it means there is chronic kidney disease. So it may be azotemic rickets. So in such cases, apart from management of the renal condition, we have to also give calcitriol. That is 125 hydroxycholecalciferol. We cannot give direct vitamin D. Now suppose serum creatinine is normal, then we will look at the blood pH. Suppose there is acidosis. So acidosis means there is renal tubular acidosis. So in cases of renal tubular acidosis, as kidney is related to vitamin D metabolism, there will be low action of vitamin D. So in this condition, there may be type 1 uh, renal tubular acidosis or type 2. So in type 1, we will do urine pH. So urine pH, if it is more than 5.5, it is type 1. If it is less than 5.5, it is type 2. Okay. Now comes if there is no acidosis. So if there is no acidosis, it means renal is ruled out. Now it may be vitamin D dependent type 1 or type 2. So if it is vitamin D dependent type 1, then as we saw earlier, we will give 0.01 to 0.1 microgram per kg per day of calcitriol. We will again monitor. If this much dose of calcitriol is not effective, then we will have to increase the doses. And if higher doses are required, then we will diagnose it as vitamin D dependent rickets type 2. Similarly, if it is hypophosphatemic, we will also do phosphorus levels. If phosphorus levels are very low, then it may be X-linked hypophosphatemic rickets, autosomal dominant hypophosphatemic rickets, or autosomal recessive hypophosphatemic rickets. Then hypercalciuria or tumor induced. So these are the conditions in which we can see rickets. Okay. So we have seen a child, there was a child, a girl, 4 years old, with brought from some rural area, and that girl was having all the signs of rickets. So initially, she was given vitamin D 60,000 units per week for 6 weeks. Calcium was given, and then she did not come for follow up. After 2 years, again she came with same complaints, and she was more deteriorated. She was not able to walk. 6 years old girl, unable to walk, almost 12 kg weight, all the signs of rickets present. Then we evaluated with this algorithm. So we gave vitamin D earlier only, so we did not repeat it. We did serum creatinine, we did pH, blood, and pH of urine. And obviously, we did alkaline phosphatase and calcium and other things. So we saw that serum creatinine was normal. So it was non-azotemic rickets. Then we did pH. pH was acidotic. So it was renal tubular acidosis. Now it was pH was more than 5.5. So it was distal renal tubular acidosis. So then what we did was that we gave correction, metabolic correction. We gave sodium bicarbonate. One thing you always remember that when we are correcting acidosis, we have to ensure that we also give ionic calcium first. Because if we don't give calcium, then correction of acidosis will lead to increased protein bound calcium and decreased ionic calcium. So it may cause tetany. So in that girl, same thing happened. When we gave vitamin D, we gave sodium bicarbonate to correct acidosis. She suddenly developed tetany and spasms, so severe that she again had some fractures. So then we realized that we have to first give calcium, correct the, we have to first give calcitriol because this is renal tubular acidosis. So normal cholecalciferol will not work. So we gave calcitriol, and then we gave calcium, and then we corrected acidosis in the last. And gradually, we also provided her orthopedic support, and then that girl was able to walk within 3 to 4 months. So in this way, her clinical condition improved. Similarly, there was another child who was operated for thyroid carcinoma, 8 years old child, and he developed suddenly post-op period, he developed tetany and carpopedal spasms. So in that child also we gave calcium, we gave vitamin D, but no improvement. So then we gave calcitriol, and with calcitriol he improved very easily, very nicely. So please try to understand. Again, I'll just give you the idea about the doses. So for treatment, we have to give 60,000 international units fortnightly for 5 doses, and calcium 200 mg per kg per day in preterms, and for older children 500 mg per day. For prevention, 400 units and 600 units, and calcium we saw 200 mg per kg per day in preterms, 250 to 500 mg per day in infants, and in children more than 1 year 500 mg. And management of tetany, laryngospasm, seizures is calcium gluconate. We have to give 2 ml per kg, 10% calcium gluconate every 6 hours for 2 to 3 days. Okay. And then we saw the algorithm. So remember that what are the indications? Again, I'm telling what are the indications of calcitriol. Calcitriol is indicated in vitamin D dependent rickets type 1, hypophosphatemic rickets, hypoparathyroidism, chronic renal disease, and chronic liver disease. So these are the 5 indications of calcitriol. And vitamin D dependent rickets type 2 requires high dose calcium. Another thing important for rickets is that most of the time we see that we tell that do vitamin D3. So what is vitamin D3? So vitamin D3 is cholecalciferol. What is vitamin D2? Vitamin D2 is ergosterol, ergocalciferol. So it is present in the plants. Vitamin D1, vitamin D1 is ergosterol plus cytosterol. Similarly, vitamin D4, vitamin D5, these are present in algae in the oceans. So these are not present in human body. In human body, mainly vitamin D3 is present. So most of the time we get confused between 125 dihydroxycholecalciferol and vitamin D3. So vitamin D3 is cholecalciferol and activated vitamin D3 is calcitriol, which is 125 dihydroxycholecalciferol. So this way we finish this topic of rickets. I hope you learned something. And I again would like to thank Doc Plexus for giving me an opportunity to present this topic. Thank you.
Thank you. Thank you so much, Dr. Ankit. To all our audience members, we hope you found our first session to be informative and insightful. Do let us know your thoughts in the comment section below. On behalf of the entire team of Doc Plexus, we would like to extend our sincere gratitude to Dr. Ankit for sharing his thoughts on the management of rickets in children. Dear audiences, thank you so much for joining us today. Stay tuned for our next session on neonatal seizures by Dr. Rajendra Prasad on 13 September, 6 p.m., which is also part of an interesting lineup of webinars we have in store for you as part of our 9-year celebrations. You can check for the further sessions, like, and as well as add them to your calendar so that you do not miss out on the clinically rich discussions we present for our healthcare community. Thank you so much for being with us today, and see you soon for another riveting session of ClinShots next week. Thank you, and please take care.